Masterclass series. Today's topic is pelvic floor disorders. It includes the urinary incontinence, prolapse staging, and treatment pathways. Course roadmap, what you will learn, a structured approach to the history and examination, a staging prolapse with POPQ system, classifying urine continence and its types, conservative medical and surgical pathways. Why it matters? Because a widespread underreported problems. The 1 in 4 women affected with pelvic floor disorders and less than 50% ever seek care for their symptoms. So they don't come. Most patients wait years before mentioning symptom, ask directly every visit. Overview, the big 3 disorders, pelvic organ prolapse, urinary incontinence, and stress, urge or mixed, and fecal incontinence and defecatory dysfunctions. Anatomy, the pelvic floor support system is a levator and eye muscle groups form the active floor. Endopelvic fascia and ligaments give passive support. And 𝗙𝗵𝗃 levels 1, 2, 3 describe the vaginal support zones. Risk factors, common risk factors are the vaginal birth, childbirth, especially the instrument delivery, advancing age and menopause, obesity and chronic straining, constipation and cough. Diagnosis, history taking, the few key questions we should ask before taking any decisions. Is there any birth symptoms like vaginal pressure, vaginal protrusion, any leakage triggers like coughing, urgency or both, and bowel and sexual function symptoms. Diagnosis on the physical examination systemic approach, exam at rest with Valsalva maneuver, assess each compartment, anterior, posterior, apical, cuff stress test with comfortably full bladder. Staging, POPQ staging system overview is standardized, reproducible measurement system, points measured relative to the hymen, and enables the consistent tracking and research comparison. Staging, POPQ stages 0 to 4. 0 to 1 is no prolapse to minimal descent above the hymen. 2, the leading edge within 1 centimeter of the hymen. And 3 to 4 is beyond the hymen up to complete eversion. The classification stress versus urgent versus mixed incontinence. Stress is leakage with cough, sneeze, and exertion. Urge is sudden urgency followed by leakage, and mixed is a features of both common in older women. Now, the diagnosis of stress incontinence, diagnostic clues are the positive cuff test with full bladder, urethral hypermobility on examination, leakage is immediate, not preceded by urgency. Diagnosis, urge incontinence, OAB diagnostic clues, urgency, frequency, nocturia are prominent. Leakage follows a strong urge, not exertion. Rule out the urinary tract infection first. Sugar, diabetes, all should be ruled out. The basic office testing, cuff stress test, objective leakage coefficient, post-void residual, rules out retention and overflow, and urine analysis exclude infection, hematuria, sugar, everything. Then when to order urodynamics, diagnosis unclear or symptoms are mixed, prior failed incontinence surgery, significant prolapse, masking underlying continence. The management, the conservative pelvic floor muscle straining, first line or mild moderate prolapse and stress leakage. Supervised training outperforms self-directed exercises and benefits typically seen by 12 to 16 weeks. Management, pessary management for prolapse, non-surgical option to any prolapse stage, fit by trial, supports versus space filling time, and regular follow-up to check up for erosion and discharge. Then medical manage for the overactive bladder, anti-muscarinics or the beta-3 agonist at the first line drugs, bladder training pairs well with medication, and reassess response at 4 to 6 weeks. Management, surgical pathway, stress incontinence, mid-urethral sling is a standard surgical option. Offer after the conservative measurement fails and high success and satisfaction rates reported. Surgical pathway: prolapse by compartment. Anterior, we need anterior colporrhaphy. Posterior, we need posterior colporrhaphy. Apical is a sacrospinous fixation to the uterosacral suspension. So decision making: native tissue versus mesh and augmented repair. Native tissue and mesh augmented. Native tissue is a lower cost, lower complication profile, preferred first line for most patients, while mesh augmented, considered for recurrent and complex apical defects, required informed discussion of mesh risk. Combined prolapse plus incontinence surgery: occult stress incontinence, sketch emerge after the prolapse repair. Consider prophylactic sling in the selected high-risk patients. Discuss trade-off, added risk versus avoiding a second surgery. Post-operative follow-up and outcome: structured visit at 6 weeks. Then usually take both anatomical and symptom-based outcomes. Ask specifically about the recurrence and new symptoms. So clinical judgment: these are the pearls and the pitfalls. Pearls are: ask about the symptoms directly. Patient rarely volunteer them. Stage prolapse before deciding on treatment, and treat the whole floor, not just the presenting complaint. The pitfall is missing occult stress incontinence before repair, treating our symptoms without excluding infection, and choosing mesh without discussing native tissue first. Key takeaways: summaries: ask about pelvic floor symptoms at a very relevant visit. POPQ gives a standardized reproducible prolapse stage. Classify incontinence type before choosing the treatment. Start conservating, escalate to surgery when it fails, and track outcomes over time, not just the immediate result. Thank you.